thank you everyone for joining in on such a lovely evening. I hope all of you will get to experience the nice weather out either before or after the webinar here today. So in terms of what we're going to be covering today, it's going to be on allergy and anaphylaxis. And this is part of our Allergy Alert program that we just rolled out this month. For those of you who aren't as familiar with whole health, one of our focuses is providing resources and running these programs to help pharmacists keep up to date with updates and guidelines and updates in products to facilitate providing that optimal care to their patients. And this topic, so allergies, is especially important to discuss as we go into the peak season, which is that summer fall time, and very timely now with pharmacy involvement and continual involvement in vaccinations, which is a trend that probably won't be stopping anytime soon, especially as we get into fall with the flu immunizations and adult immunizations throughout as well. Okay, so just a quick introduction. My name is Molly. I lead the program development here at Whole Health. And so we develop those materials that you're going to see later on in the presentation. I'm joined tonight by our wonderful and amazing co-op student right now, Mirabella Chan, who's from the University of Waterloo. She's a soon-to-be pharmacist. This is her last co-op placement. We're very happy to have her here. Very instrumental, Mirabella, in development of this program as well. So definitely one to look out for. If you have any questions or suggestions about any of our program, either this one or coming up, please feel free to reach out to me. And my contact information is at the end of the presentation. We'll also be posting a survey link near the end of the presentation, which you can fill out to get a copy of the slides as well. Okay, so just a quick disclosure slide that this webinar was made possible with support from Bosch Health. And I see Guy is on here, so I just want to thank Guy and Bosch for supporting pharmacy education. Okay, so here's the agenda for tonight. We're going to be pretty ambitious, keep it very concise, leaving time for Q&A at the end. We also have some trainers for some of the auto-injector devices. We have all three devices which are available on the market right now, so we can go over those for those of you who are interested after the Q&A session at the very end. In terms of the actual agenda, we'll first go over anaphylaxis and how to identify it in your patients and in the pharmacy. We'll then go over some updates in anaphylaxis guidelines, and then Mirabella will go into some of the opportunities that are there for pharmacy teams to use resources or to use guidelines and implement those changes into their workflow as well. Okay, so to start off, anaphylaxis. The first slide I have here is actually, we're going to be talking about anaphylaxis misconceptions. And I've just blurred the slide for a few seconds because before we go into it, I'd like you to think about any preconceptions you might have about anaphylaxis and when to use epinephrine, and any preconceptions or perceptions of epinephrine or anaphylaxis that you've perhaps heard in your patients. So the three that we're kind of going to be talking about in this first slide, first one is the fact that patients might think that epinephrine is dangerous and overused, wherein we know this is not true. Epinephrine is often underused for anaphylaxis. There's also a tendency to hesitate before using it when it really is an extremely safe and effective medication. There are no contraindications to epinephrine, so use is highly recommended and it is life-saving medication. There's actually a correlation between survival in anaphylaxis and reducing that delay between exposure and epinephrine. Some patients, in the second myth here, may have only experienced a mild case of anaphylaxis in the past where maybe it wasn't life-threatening or they didn't need to have epinephrine administered. So they may think that they're less at risk of having a severe reaction in the future, or they're only going to have mild reactions in the future. We know this is not true because the past reaction severity are not predictive of the future reaction severity. And this is why all patients with a history of anaphylaxis should be carrying that epinephrine auto-injector. And mild anaphylaxis can quickly turn into life-threatening conditions as well. In terms of the third myth, that there has to be hives or skin involvement to diagnose anaphylaxis, we'll discuss the presentation of anaphylaxis in a couple of slides, but this is a common misconception because even though it is common to have that skin involvement and those hives and that urticaria, it's not required for anaphylaxis to be diagnosed, and it's not required before you administer epinephrine. So this quick slide just goes over some statistics. I think the overall theme is that anaphylaxis and allergy, allergy in particular, is quite common in Canadians. So almost a third of Canadians over the age of 12 have allergies that have been diagnosed by a physician. Of course, not all of these are anaphylaxis. In the US, the prevalence of anaphylaxis is about 1 to 5%. And this can often be underreported as well, as in patients with mild anaphylaxis, they may not present to the emergency room, or for patients who have not had that exposure to their trigger yet. It is, something important to talk about though, because if you think about the people near you that you know that have a serious allergy that can result in anaphylaxis, it's estimated that at least 1 in 2 people know at least one person in their friends or family circle that has a severe allergy. And so we are all directly or indirectly affected by anaphylaxis. In terms of common causes, commonly can be due to insect venom, food, and medications. And this is very timely now as our provinces are coming out of the pandemic. We're opening up. Summer is around the corner with all that outdoor time and the bug stings. And so it's important to start talking to your patients now about anaphylaxis and making sure they're fully protected as we're getting back into the summertime and as we're going out to eat again and putting ourselves perhaps at risk of exposure. Okay, so this slide goes over the definition and how anaphylaxis presents. It's an acute onset reaction, so usually peaks within 5 to 30 minutes post-exposure. The way it's characterized, there's usually that skin or mucosal tissue involvement, which are the hallmark symptoms that we're used to. So with skin, it's the rash, it's the hives, it's the itching. With the mucosal involvement, it's usually swelling, so swollen lips, tongue, uvula. There can be some taste disturbances as well, like a metallic taste. So you need at least one of these, plus at least one other system involved. So whether that's the respiratory system, so breathing issues, whether that's the cardiovascular system or the GI system. I like bringing up the GI system as well and pointing that out because we often don't think of abdominal symptoms and attribute those to anaphylaxis, but it is something to look out for. Also not on this slide, but there could be psychological symptoms as well. So their patients, after their exposure, they can be feeling a lot of anxiety, the feeling of impending doom or like something bad is going to happen can be a clue that the patient is or may be experiencing an anaphylactic reaction. And just to note, the criteria that I just talked about does not need to be met if they had an exposure to a known allergen. So for example, if a patient had allergies to peanuts and then they ate something and it was unlabeled peanuts and they found out right after they bit into it, it would be appropriate to assume that they're experiencing anaphylaxis, even without all of these symptoms, if they experience just hypotension, just bronchospasm, or just any throat involvement or swelling. And often in these situations, it would be appropriate to inject epinephrine as soon as it's determined that they had that exposure, even without symptoms. Okay, so this is a quick review of the types of anaphylactic reactions that can occur. So usually, the most common one is this uniphasic reaction, which occurs within, again, peaking within that 5 to 30 minutes from exposure, lasting less than 24 hours. So for all of these reactions, it's essential to get that medical attention and to keep multiple injectors on the patient. But it's very highlighted when we are looking at the biphasic reaction, where here the patient may have that first peak, but then there is a period of from 1 to up to 38 hours where they may not have symptoms, and then there will be a second peak even without a second exposure. So this can be quite dangerous if patients don't go to the hospital because they may have used their epinephrine dose already in that first peak, putting them especially at risk. And the second peak can be either the same, less, or even more severe as the first one. In this third type here, the protracted type, this is a prolonged type. It's very dangerous with a bit of a poor prognosis, but thankfully it's very rare. It lasts over 24 hours and sometimes associated if perhaps the allergen or trigger is prolonged. Okay, so this slide here goes over some of the common triggers and cofactors associated with anaphylaxis. And as you can see here, there's a lot of triggers. There's food, insect venom, medications, other things. And there can also be patients who have anaphylaxis and there's no known trigger as well. So this is also a good place to note that in pharmacies, we often ask about drug allergies, but some of the most common allergies leading to anaphylaxis is actually that food and insect venom component. So if a patient comes in for epinephrine or if epinephrine is on file, the first step is to ask them about any known and identifiable triggers and not just drug allergies. In terms of how these triggers will trigger that anaphylaxis, they usually interact with the immunoglobulins on the mast cells in the body, and that leads to a release of hypersensitivity mediators such as histamine and prostaglandins, ultimately leading to an increase in vascular permeability in the body and a decrease in vascular resistance, thereby leading to extreme hypotension and eventually cardiovascular collapse. There are a few cofactors that can increase the risk of getting anaphylaxis or amplify the severity of anaphylaxis as well. So I'm sure most of you have heard of these three on the top here, the atopic or allergic triad, which is asthma, allergic rhinitis, and eczema. These three are associated with an increase in IgE production and sensitization, which is why they increase that and amplify that anaphylaxis, which is also IgE mediated. Other things here, like an increase in mast cells, cardiovascular disease, medications, age and sex, so younger and elderly females specifically, stress, and it could be physiological stress like infections, or it could be mental stress as well, can all contribute to amplify that anaphylaxis. And what this means is basically the amount of allergen needed to trigger that anaphylaxis is less with the presence of these cofactors, and it could be more severe with these cofactors as well. Okay, so we put this slide in here about anaphylaxis in the real world and in the news because anaphylaxis is often very tragic when it happens to be fatal, because often these cases occur in youth. Often it's their first time either not living at home when they go from a controlled food environment to going to meal plans or eating and sharing foods with friends. So it's critical to educate, and pharmacists can have a role here, especially young adults before they head off to college in these situations. You know, when they're coming into your pharmacy and they have anaphylaxis on file, maybe they're coming in for some vaccinations like meningitis before school. Then talking to them about anaphylaxis as well, and making sure that they have epinephrine on hand. Okay. Because often in these situations where there is a fatal anaphylactic reaction, the theme is that they often did not have epinephrine, or maybe they were administered an inappropriate dose of epinephrine. So in the first two cases here, both of these individuals, unfortunately, had an anaphylactic reaction and epinephrine was not available to them. In the second case here, this gentleman had the reaction, and the first responders on site were the fire department, who did not have epinephrine and reportedly did not even know how to use epinephrine either. In this third case here, it was a 15-year-old girl who experienced worsening anaphylaxis after eating a sandwich containing unlabeled sesame. So this actually occurred on an airplane. So she started feeling symptoms within a couple minutes. Her father took her into the bathroom of the airplane where both her EpiPens were administered. And unfortunately, by the time the plane landed and she was brought to hospital, she had succumbed to her condition. So in this third case here, there was actually an inquest on this case because the patient was from the UK and this happened in France. And the coroner that led the inquest ultimately concluded that both the dose and the needle length of the EpiPens that she were given were inappropriate based on UK guidelines. We'll go into guidelines in just the next slide, but both UK and Canadian guidelines now recommend that 25 millimeter needle length, which is longer than what's traditionally been offered in epinephrine products. And they also recommend the new 0.5 milligram dose for adults and children over 12 as well. But we'll talk about it just in the next slide. Okay, so guideline changes. Okay, so both international and Canadian guidance, when we're looking at epinephrine, epinephrine is ideally dosed by weight. It makes sense as well since, you know, the weight by weight dose is 0.01 milligram per kilogram to a maximum of 0.5 milligrams per dose. And it really makes sense because, you know, if you're thinking about the dose of epinephrine, a life-saving medication when the patient is having an anaphylactic reaction, would you really be using the same dose for example, a teenager who's 5 foot tall as you would for a fully grown adult that's 6'2"? And in the past, these guidelines have recommended using that 0.3 milligram auto-injector dose because it was the only auto-injector dose that was available. But now that we have the new product strength, which is the 0.5 milligrams, we can now provide the most appropriate dose for patients who are over 12 years old, who are over 45 kilograms. So we can now provide the most appropriate dose for them, and that is supported by both Canadian guides and the World Allergy Organization guidelines. Okay, so this slide goes over some of the details actually in the product monographs. So if you see this chart here, you can see that the indications are a little bit more conservative than the guidelines when we're talking about the monographs. So this can be a little bit challenging for pharmacists when we're making those recommendations, or especially those of us in certain jurisdictions who have prescribing authority when we're trying to decide which dose to go with. I think it's important to note, though, that there is a level of clinical judgment that's important to be made here. In the margins of this dosing, where ideally the dose that we're aiming for would be as close as possible to that 0.01 milligram per kilogram per dose, to a maximum of 0.5 milligrams. So we've also included needle lengths in this chart, which differ between these products, as you can see here. As we mentioned with that unfortunate case with the young girl, the needle length of some products may not be appropriate to optimally administer that dose into that intramuscular area, especially for patients who might have more subcutaneous fat in the thigh region. So female patients often carry more fat in that area. Also, any adults or teenagers who are obese or overweight, it's probably more appropriate to have the longer needle to get that delivery of the epinephrine. In terms of side effects, we've included them on the slide as well. You can read them here, but the general message is that these side effects are significantly less urgent and important than dealing with the anaphylaxis. Again, there's no contraindications, so you would want to use epinephrine in every case with anaphylaxis. There are certain people that you do want to monitor a little bit more closely for after administering it, and you would want to monitor, for example, for patients who are pregnant, who are older in age, if they have cardiovascular disease, if they have diabetes, they have Parkinson's, because the epinephrine can temporarily exacerbate some of those conditions. Okay, so I've put this slide back in the deck here just as a reminder of some of the things that you'd be looking out for before administering epinephrine. And again, you'll get the slides at the end of the presentation through the filling out the form or emailing myself. Okay, so one of the most important slides, when and how to use epinephrine. In terms of when, it's very simple, use right away. So even if you're unsure if it is anaphylaxis, it's generally recommended to give it anyways because of the risk of anaphylaxis. There's a saying, and it's probably an oversimplification for anaphylaxis, but it goes, the only time epinephrine doesn't work is if you don't use it. So I think it's quite poignant to speak to patients who may have a little bit of hesitancy using it, because we really see, and studies show that patients who have anaphylactic reactions and present to the ER, less than half of them actually use their epinephrine, even if they had it available on their person when they came in. And you know, it's so important because death from anaphylaxis can occur very rapidly. And again, a seemingly mild case can quickly turn very deadly. Okay, for how to use, we've included the instructions here. You can read them on your own, but again, as I mentioned, we have the trainers as well that we can go over at the end of the presentation for anyone who's interested. I think it's important though, when counseling patients, they should really know how to use these injectors like the back of their hand by the time they need it. Hopefully they never need it, but they should know how to use it before that time. There are a lot of free trainers available. So patients and pharmacies can go to the websites from these manufacturers for Allergy, Emerade, and EpiPen, and you can actually request free trainers to be delivered. And this is really helpful for patients to familiarize themselves with the use of these products. And it can be helpful to get their friends and family involved as well. Okay, so after talking about all of the available products, what's the difference between the three of them? So when we're looking at epinephrine products, the key points that are important for the efficacy of the drug are making sure that the timing is right. So making sure that patients, the epinephrine is available to them, making sure that they're compliant and accessible. So it's kind of related to cost and compliance as well. There's also making sure the dose is the right dose for the patient, and of course the delivery. So making sure that the needle length and the technique works out for the patient as well, to make sure that the epinephrine actually gets into the intramuscular space. So when we're talking about technique and needle length here, as we discussed in the last slide, the products are slightly different in technique. It's important to consider when we're choosing the product or we're helping the patient choose the product, to choose the one that's the most intuitive one for them, because in an anaphylactic reaction, you know, seconds are precious, right? So out of the three, probably the simplest one to use is Emerade, because it just has that one step of taking off the lid and then administering it. There was actually a small study that was done that compared Emerade and EpiPen, which found that 100% of patients were able to inject Emerade within 15 seconds, compared to only a third of patients when using EpiPen at a longer time frame. So 100% were able to inject Emerade and within 15 seconds, compared to 33% on EpiPen. So Allergy is another product that we talked about. It has voice prompts actually. So once you start to use it, it has prompts in both English and French. And this could be a good tool for patients, especially younger ones who maybe aren't as familiar with technique and need that guidance in a stressful situation. So it really depends on the patient. And so it would be helpful to go through some of these products with them as well. For needle length, Emerade is the differentiator. It has a longer needle length at 23 millimeters, which is closer to the recommended length in Canadian and international guidelines. There have also been ultrasound studies that looked at drug delivery, which showed that Emerade is least likely to result in subcutaneous injections compared to the other products. And this becomes even more notable and significant when you have to inject through clothing, for example, or when you have to inject through, you know, like thick clothing for winter, which we may likely see in colder months, especially in Canada. Another thing to talk about is cost as well. As you can see on the slide here, they are somewhat costly products, all around that $100 range, which can be quite significant for certain patients, especially if there's multiple members in that family who need it. And especially for, sometimes patients may never need to use it, which is a good thing, but it is a lot of expenditure on their end too, especially when they have to replace it yearly. So on the next slide, we'll go over some of the provincial coverage for these products, but for patients who are not covered by provincial or federal programs, there's currently an STI card that Bosch Health, who makes Emerade, is offering, and it'll cover up to 100% of the cost of Emerade in both strengths, so both the 0.3 milligrams and the 0.5 milligrams. So patients will be able to download this STI card, and they can get up to 3 auto-injectors for free, which is amazing because that ensures that they will always have these injectors on hand. Okay, so this chart goes over some of the provincial coverage. For the most part, all of the brands of epinephrine are covered either provincially or federally. So they're all covered federally through the NIHB program. For those of you who are familiar with whole health, you know that we've done a lot of work in the NIHB space, and we've made a lot of infographics and resources to help pharmacists actually access these resources for their patients. And so if this is something that you'd be interested in, please let me know as well, and I can send you some of our infographics that help with actually getting access to these benefits. So in certain provinces like Nova Scotia and PEI, there might be limits to the number of injectors, like 2 injectors, but the prescriber can submit an exception request if needed in this case. And just another note, of course, that epinephrine is covered as Schedule 2, so meaning it can be OTC or RX as well. And I should have mentioned that with the Emerade STI card, that it's available for patients who are getting it through prescription and also over the counter to be 100% covered. And there's a link on the previous slide to get that as well. Okay, so I think I'm going to turn it over to Mirabella now, and she'll go over some of the things that pharmacy teams can do.
Thanks so much, Molly. So now we'll discuss the role of pharmacists and what we can do from the moment the prescription is dropped off to the moment the patient walks away with their epinephrine auto-injector in hand in order to provide the best patient care. So there are a number of ways pharmacists and team members can intervene to provide the most optimal product to the patient. And the first step is first identifying patients who require an epinephrine auto-injector but don't already have one. So this can be flagged by pharmacists, technicians, and assistants, and it's why it's important to keep allergies and the associated reaction on file. And as Molly mentioned, not just allergies to drugs, but also to food, insect bites, and anything else. For individuals who have been prescribed epinephrine, we want to evaluate the appropriateness of the prescribed product. So for example, seeing a 0.3 milligram prescription for an adult should raise a red flag now that we know that the 0.5 milligram dose is more indicated. It's important to obtain the patient's weight in addition to allergies at drop-off and document this in their profile. And pharmacy team members should make it a habit to ask these 2 questions every time an epinephrine prescription is dropped off, kind of similar to how we always ask the patient's weight for a pediatric antibiotic prescription in order to determine the correct dose. Weight can sometimes be a sensitive topic, so you can phrase the question in a way that explains how that information will help the pharmacy. So for example, did your doctor discuss with you that epinephrine is dosed based on weight? Or you can also ask, do you mind if I ask you your weight so that we can make sure this dose is right for you? Also, by asking weight for every single patient who comes in with an epinephrine prescription, it normalizes the question and patients don't feel like they're being singled out. The next step is to recommend the optimal product based on the dose, needle length, and other factors. And finally, patient education is crucial. So the epinephrine auto-injector is of no use to the patient if they don't know how or when to use it. So we'll go through each of these steps in more detail on the following slides. Now, which patients would benefit from the zero point 0.5 milligram dose or longer needle length offered by Emerade? As previously mentioned, the zero point 0.5 milligram dose is officially indicated for adolescents and adults with a weight over 60 kilograms in the product monograph. However, the allergy guidelines support the use of the zero point 0.5 milligram dose for patients who are older than 12 years old and over 45 kilograms. So you can use your clinical judgment and consider patient characteristics and their medical history to guide your recommendation. Patients with increased body fat percentage, such as female adults, as well as adolescents who are overweight or obese, would also benefit from Emerade due to the longer needle length, which allows for better delivery into the muscle, as mentioned before. And then finally, we want to evaluate the patient's history of anaphylaxis or any other cofactors they may have, such as the atopic triad or certain medications, as mentioned before. So if a patient is 50 kilograms, for example, but also has cofactors, it is supported by the guidelines to use the zero point 0.5 milligram dose. Okay, so let's review the possible drug therapy problems that we may encounter when reviewing an epinephrine prescription based on what we now know about the different epinephrine products on the market. So the first drug therapy problem, possible drug therapy problem, is too low of a dose, taking into account the patient's age, weight, and clinical judgment with other patient factors. The second is inappropriate needle length based on age, gender, and body fat percentage. Another possible DTP is that only one epinephrine auto-injector has been prescribed with no repeats, because we know that patients should always have two pens on hand. Another is compliance issues due to the administration technique of the particular device. So as Molly mentioned, all three of the devices work in different ways. And then the final DTP could be cost. Okay, so we've evaluated which epinephrine auto-injector product is best for the patient. Now, how do we actually go about making this recommendation? First, you want to offer a private counseling area to speak with the patient and explain to them that epinephrine dosing is based on weight, as well as other factors that may put them at higher risk of anaphylaxis. It really should be a two-sided conversation that involves the patient's preferences as well, such as cost or the mechanism of the device. And if the patient is comfortable with your recommendation and you are in a province that does not allow for pharmacist prescribing, you can contact the prescriber to change the product. So in Ontario, you can do this via pharmaceutical opinion form. But also for whole health pharmacies, we've created a recommendation template that outlines the guidelines in order to help facilitate easier communication with prescribers when making the recommendation. So as mentioned before, patient counseling is a crucial part of the pharmacist's role in anaphylaxis management, and counseling shouldn't be rushed. So if it's too loud or too busy at the counter, you should offer to speak with the patient in a counseling room so that you're able to provide that proper education. So on the slide here, we have a few key counseling points. So we want to first and foremost provide education on how to recognize the signs and symptoms of anaphylaxis and review the emergency protocol, as well as demonstrating how to administer the epinephrine. And you can demonstrate with a trainer and have the patient teach back with the trainer to make sure that they understand how to use it. We also want to make sure that the patient knows to carry two auto injectors at all times in case a second dose is needed, and also to make sure to know when to replace them. So for example, if it's leaking or the solution is discolored. I'll also make a note here that in addition to auto injectors, you can advise the patient to always carry their cell phone or medical ID with them in case of an emergency. So I know on the iPhone and Android, there's actually a feature to add important medical information such as allergies or medical conditions, which can be accessed from the lock screen on the phone. So you don't have to unlock the phone to access that information. So that can be helpful. For example, if you are unconscious and someone finds you, they're able to check your phone to see for example, that you have an anaphylactic allergy, you probably have an epinephrine auto-injector on you. We also want to emphasize epinephrine access when the patient goes back to school, camp, going to travel somewhere, and also ensure they have a written action plan to give to family members, teachers, or camp counselors. And as mentioned before, patients can also obtain a free trainer device on the manufacturer's website, not only to practice for themselves, but also to teach family members or teachers. We also want to optimize the management of any cofactors such as asthma. So that means reevaluating therapy, reassessing proper inhaler use. And pharmacists should also provide refill reminders when it's been 2 years since the last fill date, because that probably indicates that their pen is currently expired. And then finally, we want to ensure the patient knows to follow up with their allergist annually. This can often be forgotten about if the patient has not experienced anaphylaxis in the past year or has had to use their epinephrine auto-injector. So we just want to make sure that we remind these patients. And just at the bottom here of this slide is an anaphylaxis action plan template that patients can download or print out and write down their action plan. And Molly will be sending out these slides at the end if you fill out the survey, so you're able to click on that link. Okay, so now we're getting into the anaphylaxis protocol. So I will just preface this by saying that although these are labeled in a stepwise fashion, most of these will realistically be done simultaneously. So for example, you will likely be assessing the ABCs or the airway, breathing, and circulation while you're calling 911 or you're on the phone with an operator. After assessing the ABCs, you will want to inject the epinephrine into the outer thigh. And it's important to note for children, young children, you want to hold their thigh in place to prevent them from moving around a lot. You also want to make sure the patient lies down, preferably with their legs elevated. And the exception to this is if they're vomiting, then you would place them in recovery position, or if they're having trouble breathing, then they should sit up. If there's no response after 5 minutes, you should administer a second dose. And this goes with any epinephrine auto-injector. So there was a question earlier that was asking if a second dose is needed with Emerade. And yes, the second dose, if there's no response after 5 minutes, it's needed with any brand. And then of course, if the patient isn't breathing, you would administer CPR. So by that time, hopefully the ambulance has arrived. You always want to make sure that the patient is transported to the hospital, even if they do respond to the epinephrine and they feel fine afterwards, because as Molly pointed out in the beginning, there is that possibility for a biphasic reaction. So we just want to make sure they get the proper care in the hospital. Now, there are some common misconceptions that antihistamines such as Benadryl can be used to treat mild anaphylactic reactions. And while they can help with the cutaneous reactions associated with anaphylaxis, they don't work to reverse the respiratory or cardiovascular symptoms, which is what epinephrine is for. And then another important note is that while bronchodilators may help relax the smooth muscles in the lower airways, so the lungs, they do not reverse the mucosal edema in the upper airways or the throat. So that being said, it may be used if the patient is unresponsive to epinephrine, but it shouldn't be the first thing that's given. And finally, this slide reviews the pharmacy's journey in receiving and dispensing epinephrine auto-injectors and at which points the pharmacist can intervene. So we have the initial drop-off of a prescription, or someone is requesting an epinephrine auto-injector as over-the-counter. At that point, we want to review the patient's age, weight, and any allergies on file, assess the prescription. If a DTP is identified, we want to engage that patient in the conversation to optimize treatment, and then if needed, make that change. And then when the patient comes to pick up their auto-injector. We want to educate on anaphylaxis protocol and technique. Some ongoing points that we want to ensure are that we want to always make sure that that allergy on the patient's profile is up to date. So for example, anytime a patient comes in to drop off a prescription, whether it's for epinephrine or not, always ask if there's any changes in their allergies. Also reviewing protocol and technique of the epinephrine autoinjector to refresh the patient's memory, and reminding patients to refill annually when their autoinjector has expired. So just an important note that falls outside of this timeline is that pharmacies should always keep at least 2 auto-injectors in their emergency anaphylaxis kits and inspect them every now and then for discoloration, expiry, or leakage, and replace or rotate them when necessary. So now I will pass it back to Molly to wrap up our webinar.
Thanks, Mirabella. Just a little bit freezing on my end. There we go. Okay, so this slide is just a review on some of the program materials that we've developed for pharmacies in relation to our allergy alert program and anaphylaxis. So again, at Whole Health, we really aim to create these practice tools to make it easier for our pharmacists to catch up with the latest recommendations and products and make those interventions at the pharmacy level. So we often make both educational and operational supports. So with our educational supports, we'll make infographics to help them with those key clinical details that they should be aware of for the condition. We'll provide operational supports such as our pharmaceutical opinion templates and pharmacy recommendations. And then we'll also do a variety of awareness materials as well. So these materials, we'll share them on our social media. So if you guys haven't checked out our social media yet, please feel free to do so and you'll see some of those there. We also create tools for both patient-facing and also for pharmacy teams as well. Okay, so thanks everyone for listening in. If you have any questions, we can get started on answering them. But again, please follow us on social media. If you want to reach out to me for any questions or additional resources, feel free to reach out to myself. My email is on the slide there. And of course, fill out that form as well.
Okay, so I see some questions already in the Q&A box.
Yeah.
Okay, so one I see here is, should have patients fill out medical alert info as well? Yeah, as we, sorry. Oh, okay, I'll go. Yeah, as we mentioned, you should have the medical alert information filled out. If they can get a medical alert bracelet, that would be really helpful, as well as those features on the iPhone or Android. They can add their allergies there, and then it will be accessible from their the lock screen. So you don't have to actually go into the phone to see it. Another is, what about the storage of the products by patients?
Yeah, that's a really good question in regards to storage. Let me go back to a previous slide. Oh, here. Sorry, my computer is a tiny bit slow. It's not really working with me today. Well, we do have the storage conditions listed on our slides here, which you'll get at the end of the presentation. Usually we want to store our EpiPens or Emerades or Allergex. We want to store them at room temperature. There have been situations where, patients accidentally leave it in the car in the summer when it's hot, or for example, if the product gets frozen in the winter. If that's the only thing available to them during that anaphylactic reaction, then it's better than nothing. But in case those situations occur, it would be recommended that they get a new auto-injector as well, because the heat and the cold can affect the amount that's delivered. So how much is still viable in the product.
Perfect. There's another question here. Can nitro spray be used in tandem with epinephrine if the patient has chest pain?
Yeah, so I think that's a really good question, to be honest. I'm not sure if Mirabella, you know the answer to this. I'm not quite sure, but if we're thinking about the ways in these two products for use, whereas nitrospray is being used for angina and epinephrine is for anaphylaxis, it doesn't, one product doesn't address the reasoning behind why you would use the other product, right? So unless there was a significant interaction, which I'm not aware of, but would need to double check, you would want to administer.
Yeah, I'm not sure of the specific answer as well, but I think what you said makes sense. Okay. Would the STI card be able to cover multiple Emerade to satisfy the two needed? Is it linked to a patient?
Go ahead and answer that.
Yeah, so the STI card for Emerade can cover up to 3 pens. So like the one card is for 3 pens and it's for a patient who has never used Emerade before. So it is linked to a patient if they try to use a card again and like it is seen that they have used Emerade before and they've already claimed their 3 pens, then they wouldn't be able to like get another one.
So I'm just going to jump in there, Mirabella. Completely correct that you can get up to 3 pens per patient with each STI card, and patients can get a unique STI card when they go into the link there at emeradesupports.ca. The requirement that the patient needs to have never tried Emerade before, that is specific to Quebec. And so in other provinces, they can still get a free Emerade auto-injector if they have used it before as well.
Okay. Is Benadryl still an option in anaphylactic reactions? What about Reactin? So we kind of answered this in our slides, but so Benadryl or Reactin shouldn't be the first thing that you give. It may help with the cutaneous symptoms such as rashes, but it won't help to, for example, open up the airways or increase the blood pressure. So that's really why you need the epinephrine. But like as an add-on, it can help with skin symptoms, but not like not to prevent it from being a fatal outcome.
Exactly. So Benadryl can still be used as an additional item, but we know that epinephrine has to be that first line ingredient because that's the one that's going to prevent that fatality.
Okay. I think this is more of a comment than a question, but just to let everyone know, expired products are all credited fully by manufacturer. So stock extra, even though expiry may be short. Better to have on stock always. We also need them for certain clinics, such as vaccines.
Yeah, that's a really great point. Especially, it became very apparent when we were having those that shortage a couple of years ago with EpiPen, where the manufacturer was recommending that you can use it way past expiry date. In those situations where a patient has that expired product, you know, it's better than nothing. You want to make sure that they check the liquid inside to make sure that there's no particulate matter, to make sure it's not discolored. But in situations like that, they would still administer.
So is EpiPen Junior safe for infants? From what I read, it seems to be recommended over drawing up epinephrine from an ampule. I wish there was a low dose auto injector for infants.
Yeah, that's a really good point. So usually for infants, if they're less than 5 kilograms, in the Canadian immunization guideline, they don't specifically recommend that 0.15 auto injector versus the ampule. There is, however, going to be, I believe, a newer product, the 0.1 milligram, which may be available shortly on the market in the next little while as well. It's more so for pediatrics.
Thanks, Molly. And one last question here that we have so far is, can a patient get a 0.3 milligram and a 0.5 milligram Emerade with the card?
Yeah, so that's a really good question. I believe you can. I know Guy is on the call here from Bosch. If that's incorrect, feel free to chime in, Guy, but I believe you can get both strengths for with that card.
Perfect.
So let us know if you guys have, yep, Guy says, yes, you can get both strengths for one patient. So yeah, that's very excellent. And thank you so much for all the kind comments, guys, in the chat. Very appreciated. So let us know if you guys have any other questions. If not, maybe I'll go back to the slide where we have how to use the products, and then we can talk about each one for whoever's still interested to stay on. Thanks so much, Raj. Okay, so we can start. Let's just start with the Emerade because that's what I have in my hand right now. So you can get the trainer again. You can go to the Emerade website and you can request the trainer either for your pharmacy or you can tell your patients to do so. It's very simple. It comes like this, and you can show your patients too. The trainer has also the steps on the back. And it is very simple to use in terms of when you actually use it. So for example, if this is the thigh of the patient and this is the hip, this is the foot, and this is the outer thigh region where you would want to inject, the steps are to take off the cap and then basically inject, and then you'd want to hold it in place for 3 seconds. And then that's it. Okay. I think a lot of us are familiar with the oldest product on here, which is the EpiPen. So a little bit more complicated with this one in terms of the fact that there's 2 openings, right? We have the safety cap here, which there's a hole here. There's also a hole on this side. Sometimes patients get a little bit confused. So it's important to tell them when using this that they should be holding it in the middle so as not to inject their thumbs accidentally or any of their digits, because sometimes when they get it in their digits, it can lead to severe vasoconstriction and actually amputation of certain digits. So when we're actually using it, again, this is our thigh. We want to take off the hold the pen with the orange tip pointing down. We want to remove the blue safety cap by pulling straight up. And then we want to press the orange tip against the thigh and then hold it in place for 3 seconds again. And then once you take it out, the safety cover will cover the needle. And I'll let Marabella do the Allergy.
So I can show the Allergy. So it is a bit different than the other 2 in that it's more of a box kind of looking shape rather than a pen. So this is the trainer, and as Molly mentioned, it is voice activated, so you will hear it in a moment. But what you're going to first do is there is an outer case on here, so you're going to first pull this up to remove the case.
This trainer contains no needle or drug.
Okay. The next thing you're going to do is pull.
If you are ready to use, pull off red safety guard.
So pulling this off.
If not ready to use, replace the outer case.
My fingers are a bit slippery.
To inject, place black end against outer thigh, then press firmly and hold in place for 5 seconds. 5, 4, 3, 2, 1. Injection complete. This trainer may be reused for training purposes.
Okay.
There we go.
Very talkative trainer there.
Yeah.
So we had a comment. So as most adult men are over 60 kilograms in weight, I guess that it would always be recommended during counseling or recommendation to recommend Emerade, and that's true. So most adults are within that range, especially if we refer back to the guideline updates as well in both international and Canadian guidelines, even not just adults, but over 12 years of age, we have this guideline recommendation where the 0.5 milligram is the most appropriate and the most safe as well. So definitely if they are adults, that is a very obvious trigger. Another question, do you need to swing into the thigh or hold and push into the thigh? So you can swing, or you can, I know on the EpiPen training device, the instructions are to swing and firmly push. So as long as you get the dose in there, I think it's a little bit tougher with the EpiPen to kind of get it to go off. It requires a little bit more strength. So especially in younger children, that swing may be more appropriate.
I did read in terms of swinging into the thigh that sometimes it's not recommended because there have been cases where like the needle missed. So you don't want to kind of inject it in the wrong place. So holding and pushing into the thigh is just as effective, but if you can do it properly with swinging into the thigh, then that works as well.
Definitely. That's great insight. Question, do we rub the area of the injection or not? I believe you can rub it. Let me know what you think, Mirabella.
Yeah, so I read that you do rub it to kind of disperse it quicker.
Okay, perfect. Okay, so I think we're coming up on the hour. If there's any last minute questions, feel free to ask now. If not, thank you so much everyone for joining this evening. We will be downloading the presentation and it'll be available on YouTube as well. We'll send out the recording when it's available. But thank you so much for your excellent interactivity and your questions. We really appreciate it. And yeah, feel free to reach out if there's anything else that we can help you with.
Yeah, thanks so much everyone for coming.